Dear colleagues, it's a pleasure to open this dialogue on the special edition of EADV 2025. And it is a great pleasure to be here together with Professor Zhenying Zhang. Myself, I'm Peter van der Kerkhof. I'm a senior professor of dermatology at the Radboud University Nijmegen Medical Center. I'm specialized in psoriasis, but I have been for nearly 40 years a teacher in dermatology, and I have trained dermatologists, junior dermatologists, to become a dermatologist, and also involved in research on psoriasis, disorders of keratinization. We are here now at the EADV. Lisa, can you give an introduction actually of yourself and of your fields of interest to our colleagues?
Thanks, Professor Peter. It's my great honor to be invited here. I'm Dr. Zhenying Zhang. I come from Hong Kong University Shenzhen Hospital. I have been a dermatologist for more than 20 years. My major special interest is psoriasis and inflammatory skin disease. In my daily life, I do some clinical trials and a little basic research about psoriasis,
yes.
pathogenesis of psoriasis. That's all. Thank you.
That's great. So we are here now together at the EADV, where there are so many different presentations in so many different fields. Mm-hmm. But I think also for our fields of interests, we can learn a lot. It's so nice to give this learning to Chinese dermatologists via this program. Maybe, Lisa, we can address first a very important aspect to give insights in the comorbidities of psoriasis, and then maybe starting with psoriatic arthritis. We all know that psoriasis can be complicated with psoriatic arthritis. Then the question is, how as dermatologists can we contribute to early diagnosis? Have you views on this, Professor Zhang? What is your insight? Then does it make sense to treat patients with psoriasis also to prevent the occurrence of psoriatic arthritis?
Okay. First question, I think comorbidities of the psoriasis, right? With the PSA data from my dermatology department patients, we found that about 20% psoriasis patient will experience PSA.
That's a lot, huh?
I think it's a large number. I think we should pay great attention to this population. Second, complications, cardiovascular
comorbidity,
is more severe. Myocardial infarct and stroke is the main cause of death among the psoriatic patients. Also should pay good attention to this population. Third one, I think, is the MS, metabolic syndrome, a large population, including maybe hypertension, hyperlipidemia, or resistance. Obesity is a great phenomenon issue in China's daily life.
Actually, dermatology has changed of being a discipline for diseases of the skin to diseases of the skin in relation also to the comorbidities. And when we go then to psoriatic arthritis, that is fully developed psoriatic arthritis and patients fulfill all the criteria, aren't we a little bit late? Then psoriatic arthritis is fully developed and there may already be damage of the joints. Of course, it's very important then to collaborate well with the rheumatologist, but my difficulty often is in a stage that the patient only says, I have some pain of the joints or has some extra fatigue. There are some signs of psoriatic arthritis, but not yet fully developed. Do we have a role there? What can we do as dermatologists then?
Yes, I have some communication with the dermatologist, but as you know, there is no definite biomarkers to predict.
No,
Yes,
no, that's right. I wish we had the biomarker and we simply could say these patients are on the way. Looking, for example, of a patient with nail disease and scalp psoriasis or an obese patient are also risk factors for the development of psoriatic arthritis. And when you see such a patient, are you then extra aware of psoriatic arthritis?
I will ask my patient do a questionnaire to
Yeah.
inquiry the foresight.
That's great. For then you are extra aware indeed that these patients may develop psoriatic arthritis so that we are early.
And after that, maybe we will ask them to do the MRI or ultrasonic detection.
Exactly.
Yes. And after that, we will try to score for the past criteria or some other criteria.
Yes.
One is highly suspected the diagnosis of the PSA. We will refer the patient to the rheumatologist to make a definite diagnosis.
I think that's great. It's also compatible what we do in the Netherlands, actually. That's indeed the same approach. And when we look at metabolic disease and cardiovascular risk factors, actually, what is your approach when you see an obese patient with psoriasis? Do you say, well, the patient is obese, it's not my problem, it's a problem of the patient? Or do you also address obesity?
Yes, I have an assistant follow me in my clinical practice. I will ask her to calculate the BMI for every psoriatic patient. When the BMI is larger than 25, I will tell the patient you should control the body weight because the decreased BMI contribute to improve both the psoriasis and the metabolic parameters.
Exactly. It's important for the health of the patient, but also for the extent of psoriasis, the severity of psoriasis, that by decreasing the body weight, you can improve psoriasis and you improve the health of the disease.
Yeah.
But sometimes very difficult when you say to patients, you should lose weight, and then they come back and they even are more obese. And then they tell you, I have done everything to lose weight, but it's sometimes so difficult. And maybe it could also be that patients with psoriasis have a genetic predisposition for obesity. But maybe that's just the reason why they need also to lose weight. For I think they are increased at risk, isn't it? You can get heart infarction at a very early age. And in elderly patients with psoriasis, we see that more than 50% of them has hypertension, and we see a lot of patients with dyslipidemia.
Yeah.
So we have got to do something.
We will also refer some overweight patients to the endocrino.
You do that. That's good. That's important.
Receive the GLP-1 injection to control the body weight. I think it's a novel treatment.
Yeah. When we look at metabolic syndrome in China, is there a change over time? Have you the feeling that in some areas of China that there is an increase of metabolic syndrome, that you see it more often now during the last years? Is there a change in lifestyles?
Yes, maybe the diet structure and the lifestyle with the changing of the diet structure and the lifestyle. Increasing number of the patients suffered the metabolic syndrome. The increasing number of patients with MS, it also bring a big difficulty for us to treating some inflammatory dermatitis, I think.
When we move then to the treatment of psoriasis, and for we have discussed a lot of metabolic syndrome, isn't it, Lisa? I think we can maybe move also to anti-IL-17 and anti-IL-23 treatments. And when you look at these treatments, what is the position actually at the moment of anti-IL-17, anti-IL-23 treatments, in what stage of the disease do you think that these treatments should be positioned in China?
In China, I think the rationale, maybe the MS and the psoriasis share similar pathogenesis, some cytokines both involved in the two syndrome.
Yeah.
From the rationale aspect, maybe the biologic administration can prolong the progress of the syndrome, but we have no direct evidence.
That's right. When I read literature, my interpretation of the literature is that, especially with respect to IL-17 signaling, that IL-17 signaling contributes also to atheroma plaque formation and to metabolic syndrome and also to cardiovascular risk. And also there is some evidence that treatments with anti-IL-17s the most of the research has done with the anti-IL-17s in this respect. Some research have done with anti-TNFs and also the anti-IL-23s. But anyhow, that on these surrogate markers, we find an effect. But when we look at the comorbidity in patient registries, so real-world evidence studies, then I have the feeling that it is so multifactorial, the pathogenesis of cardiovascular disease and metabolic syndrome, modifying only IL-17 signaling may be not sufficient enough to decrease the whole comorbidity. But when we look at surrogate markers, for example, atheroma formation and several cytokines also in the arterial wall, we see effects. So I have a positive feeling that with anti-IL-17s and anti-IL-23s, not only to psoriasis, but also we contribute to the risk. But I think further research is indeed maybe needed.
Yes, maybe some prospective design.
Yes, that's
RCT,
a good idea. Yes, a prospective cohort and then a long-term follow-up.
But not respective cohort. No. We only have the evidence from the observational retrospective cohort. Yes. So I think the evidence level is very low.
Lisa, when a patient with extensive psoriasis, difficult psoriasis is coming to me, and when I follow the guidelines, then our guidelines often are a stepwise approach. I start with a topical, and then according to the guideline, then I move usually then to methotrexate or cyclosporin or acitretin, depending on the comorbidities. Maybe next step is to go to adalimumab as one of the first biologics, where also biosimilars are available, so at a reduced price. And then quite late, I move to an anti-IL-17, anti-IL-23 treatment when I follow the guidelines. But when this patient tells me, Professor, look, I am in a terrible situation. I have a young family. I want really to be able to go to the swimming pool with my children. And also in my family, there is cardiovascular disease and some risk factors for psoriatic arthritis, like nail changes, like scalp disease. Then I don't follow the stepwise approach.
Me too.
I immediately, straight on go in such a patient to an anti-IL-17 or an anti-IL-23. And it depends a little bit when the patient has a more comorbidity risk. I tend to go more for an anti-IL-17. When it is more only psoriasis of the skin, maybe I tend to a little bit more to anti-IL-23. That's my approach.
Yes.
But what's your approach?
The same opinion.
Yeah?
As we advocate early intervention, especially for high-risk patients who will develop the PSA and MS, or just like what you said, refractory psoriasis. And we also met some patients who under the treatment from the methotrexate, TNF inhibitor, IL-17 inhibitor, IL-23 inhibitor, but they seem to lose, after sequential treatment, they will lose a response for every kind of agent.
Kind of tips.
Yeah,
that's right.
Yes, I think it's very difficult.
And therefore, it's good that we have various approaches, isn't it? We can change when there is a loss of efficacy. Now, are here at the EADV, and I'm impressed also the changes that are now there, the innovations in a way that indeed the treatments in psoriasis, that there is a tendency to go much more for early intervention. Can you tell me something what your impression is about early active intervention, and what is your approach? What do you bring from this Congress back to China in your practice, inspired by thoughts about early intervention?
I can't agree with more less ideas. I think we should do some risk stratification with the patient. In low-risk patient, we can follow the guidelines, level up treatment.
Yes.
But if we met some patient in high risk, we should advocate the early intervention. Hit early.
Hit early, but especially in those patients where you expect that severe psoriasis may develop. We should not let it happen.
Yeah, maybe level down.
In your ambition in the treatment of psoriasis, do you strive for clear skin, nearly clear skin, or are you satisfied when your patient is satisfied too?
Our guidelines suggest us to treat to target.
Treat to target, I know,
we regard the PASI 19 and PASI 100 as the target.
Yes.
That's our goal.
I think that's great. I told you I looked in the Chinese guideline, and I can look in the Chinese guideline these days then I select, and then I go to Google Translate, and then you see in perfect English, you see the guideline translate immediately. And I was indeed impressed also. The Chinese guideline is ambitious, and that's good. And of course, you can maybe not always reach the target that's there, but there should be an attempt.
Yes, but the data in Chinese population, I think that the efficacy is much better than the data in Europe. Maybe
yes,
perhaps
I think so.
Perhaps
that's
related with the body weight or the gene background. I think
the genetic background is different, and that is for sure. The frequency of psoriasis in our country is about 4 to 5%.
Most of our patients can achieve that goal, but for some special patients, refractory patients, we will use the combination. For example, the biologic combined with the.
Maybe a last thing for our discussion. That's of course what's next, what's in the future, what's coming up. And I'm impressed by the results of new oral treatments. We have already deucravacitinib, we have apremilast, but I see now also there is also a new 2 inhibitor with a very high efficacy, and there is coming up also oral molecules hitting IL-23 and also anti-IL-17. Is that advantageous, you think, to have oral treatments in the management of psoriasis, advantageous over the biologics? But how do you look at the future?
IL-23 or 27 small molecule drugs are still not available. But we have the TYK2 inhibitor and the PD4 inhibitor. TYK2 inhibitor, I think, bridged the great gap between the conventional DMARDs and the biologic. It's very efficacious. Great. It
enormous efficacy.
And I think the safety profile is good.
Good, huh?
So far.
A good safety profile for you don't need blood investigation, so easy. And of course it is important also for we also noticed at the symposium that the International Psoriasis Council have defined failure to topical therapies when 2 courses of 4 weeks with adequate topical treatment have not resulted in clear skin or nearly clear skin. And that means that there should be an easy approach then to systemic therapies. And when there are treatments where no blood investigation is needed in the future, having an effective approach and a safe approach, for it should be safe, then I think that is great, the innovation.
It's amazing result, amazing development. The ongoing research now, I review the literature, is about exploring the small molecular medication in some IL-23, Th17 cells-driven conditions, and most the research is about the combination of the head-to-head comparison.
Yes. And of course, that will help us when we have head-to-head comparative studies on one hand, and on the, for we need a personalized approach at the end of the day. For every patient has its own psoriasis, and we have to adapt actually to psoriasis and to its comorbidities. And the future is bright. And also, we will see now also in other diseases as psoriasis, important innovations.
Yes, maybe early intervention, precision medicine, AI-powered medicine, or some MDT therapy, maybe the trends of the full trends in pathologic control.
So I think we agree the future is bright, isn't it? Well, colleagues, I hope that you have also enjoyed these topics. We enjoyed it to speak about that. And we hope to inspire you that you follow the special edition and have also some discussions around these topics, also with your colleagues. And then we hope that EADV 2026, it will be again progress, great innovations in psoriasis, but also in other diseases, especially inflammatory disease of the skin. Thank you very much.